Welcome to the Fix Your Sciatica podcast, where we meet with experts and clients and discuss how to manage your sciatica and low back pain without the use of medications or surgery. I'm your host, Dr. Ashley Mack, and I'm a physical therapist as well as the founder of ifixyoursciatica.com, a go-to resource for pain management. The last time I interviewed a chiropractor was about 2 years ago, and I was a new podcaster and was just still trying to get the reins on how to interview people and how to interview experts specifically. And so I think it's about time that I had the opportunity to interview another chiropractor and talk about all the various different mechanisms necessary to help the body recover, especially with dealing with sciatica pain. So today I have Dr. Mark Testa, who is a chiropractor, as well as a part of a fantastic company in which hopefully you'll hear another episode talking about the company that he's a part of. But Dr. Mark has been kind enough to share his time and expertise so we can talk all things chiropractic care. So Mark, thank you so much for being on today's episode.
Yeah, thank you so much, Dr. Mack. I appreciate it.
And I appreciate you. Please call me Ashley on this too. So for the listeners out there who might not have heard your name before, tell us a little bit more about yourself, what your journey is, and where you're at today.
Yeah, I've taken an unconventional journey as a chiropractor. I got out of school in Southern California in 1990, and I was shocked to find out I was a quack. I swear to God. People were like, chiropractors are quacks. You hurt people. I mean, I didn't know. I grew up going to chiropractors. We got a lot of relief from them. They turned us on to a lot of holistic stuff. And even when I was like 16, I knew this was a direction I wanted to go in because, the relief and what they were doing to the musculoskeletal system. And so I ended up finding my way to working with physicians really early on in the mid to late 90s, which was really kind of novel back then because even physicians considered us largely quacks for numerous reasons we won't get into. There's a history, deep history behind the AMA planting that seed in the 60s and 70s. But nonetheless, I found myself wanting to practice with physicians. I felt like I could really add a lot of value to what they were doing, help them expand their continuum of care. And so it was probably late 90s. I started working with a primary care group in Boulder, Colorado, and continued to work in primary care. I ended up working in the largest primary care practice here in Colorado for numerous years. I worked in one of the largest physiatry pain practices on a hospital campus for about 8 to 10 years. I worked in the largest Ahmed provider in the United States, delivering acupuncture primarily, but also chiropractic. And then spent time at Denver Health in a hospital system, still largely doing work comp, but, I spent my whole time with physicians, primary care, pain management. I even worked in a spine surgeon's office for several years. Always had great PT around me, and was able to, go to the specialists, go to the surgeons, go to the physicians and say, hey, I need some help with this, or this person isn't responding. Can you help me with this? But on the flip side of that, I also saw a lot of failures. I saw a lot of surgery failures, particularly spine, certainly rotator cuff doesn't always go smooth. And as you know, as a physical therapist, that rehab is brutal. And people don't always get their range of motion back or get out of pain. And even in our pain practice, I just worked there. It wasn't my practice, but I saw 4 opioid deaths in 1 quarter in a 3-month period. This was in the Purdue, heyday. And all of this stuff was so shocking to me. But I got to see that side of medicine. And I really feel good that I was able to bring in more natural care. In the late 90s, early 2000s, I helped Boulder Community Hospital develop medical staff privileges for chiropractors and acupuncturists. And when I got to Denver Health 11 years ago, they said, how do we add you to the medical staff? We've never done this. Well, we built those documents in Boulder to be transferable around the state to any hospital. So I got those, handed them to them, and boom, now I'm the first chiropractor on the medical staff there. So really an unconventional pathway for most chiropractors, at least starting in the 90s. Maybe it's a little different nowadays. Hopefully it is.
That's a really cool journey. I think you brought up a very interesting point throughout this entire journey. I was looking at the theme of looked at it like a theme of collaboration, which I find to be very valuable. And when you get into an area, say such as sciatica pain, and there's so many various different professionals that are helping, you're going to be coming across people who are going to say, surgeries aren't going to work. This thing's not going to work. Medical professionals aren't going to work. And it ends up creating this combative environment. It's an us versus them. No one else is going to fix you but me. And it creates an unfortunate narrative and environment where you have a clash of professions. And I think with what you've been describing, you are really capitalizing on this concept of interprofessional collaboration. And so listeners out there, there's two terms out that you should be looking out for, or you might have heard or come across of. You have interprofessional interactions and collaboration, and then you have intra-professional collaboration. And what's really interesting is that when you have a group of people, say like a bunch of physical therapists who collaborate amongst each other, that is intra-professional collaboration. That's where we're looking at the same background, focusing on solving a specific problem. But truth be told, the pain that you're dealing with is multifactorial. It's including your behaviors, it's including the biomechanics, it's including the actual physiological processes that happen. And so what that means is it's really important for you to be able to have a medical team that is actually collaborating together, the interprofessional collaboration, which allows you to get every single aspect. And if you've been dealing with sciatica pain for a long period of time, it can be a little frustrating where you're having multiple different professionals. But it is important to be able to, it's important to understand that everyone is on the same team to help you. So that's the big point I wanted to share. Let's talk a little bit more about chiropractic care. I think a lot of people, when they think chiropractic, they think just cracking everything. So in short, can you tell us a little bit more about what the chiropractic profession is? What are some of the things that you look for? And what are some common ways that you use to treat pain?
So the chiropractic has got a very broad spectrum and a big history, and there's two sides to the coin. So there is the vitalistic side of chiropractic with the subluxation, the vertebral subluxation, the misalignment of the vertebrae, compressing a nerve, altering the flow of the body's innate healing intelligence. Now, I absolutely believe there's an innate healing intelligence, right? There's chi in Chinese medicine. There's prana in Ayurvedic medicine. There's innate in chiropractic. I mean, there's some living force that keeps us alive. And you really notice this when you're dissecting cadavers, like there's something missing here, right? So I absolutely believe in that. And so, the vitalistic side of chiropractic believes really that getting that alignment of the spine as optimal as possible allows that innate healing intelligence to flow throughout the entire body. Now, if I'm sick, I'm going to go get adjusted, right? But I am not going to try to cure cancer or multiple sclerosis or other things with an adjustment. That's just not the way I was trained, and that's not how I ever practiced. There are chiropractors that do practice that way, and I think maybe this is a good adjunct to other things that you're doing, right? But it should not be done, in my opinion, only by itself, right? There's exercise, there's nutrition, there's specialists. Sometimes we need medications and drugs and other things. Then there's where I have all my experience on the mechanistic side of chiropractic, where that joint misalignment now is looked at a little bit differently. We call it segmental dysfunction. It's that segment. It's not moving properly. It may be moving too little. It may be misaligned and irritating a joint. It may be moving too much because there's ligamentous laxity. The muscles around it are reacting by spasming because the body knows through afferent and efferent signaling, meaning signals coming from the brain to the body and from the body to the brain, that something is not right. And so there may be spasms, there may be edema around that area, there may be hypersensitivity around there. It may be that sciatica going down your leg, right? Where those lower lumbar segments are just misaligned, the disc is a little irritated, the intervertebral foramen where the nerve comes out may be slightly narrowed, but that nerve, those nerves going down the leg, into your butt, into your foot might be getting compromised, might be getting squashed. And it's not just physical, it's also chemical irritation. So when those joints get misaligned or the disc gets a little irritated, they leak chemicals that can be pro-inflammatory, that can irritate nerves. And so those are the two sort of sides of the same coin of chiropractic. I think when people are looking for a chiropractor, what are you looking for? Are you looking to get out of pain and get this relieved? Are you looking for an adjunct to maximize your health? Because they can be kind of a little bit different in their philosophy. The vitalistic side might want to see you very frequently, where the mechanistic side with me, I can usually tell in 6 visits if I can help you or not. And that's where, to your point, that interdisciplinary collaboration came in really handy, because after about the 4th, 5th, 6th time, if you're not making improvement with the tools I have, which I'll get to in a second, then I'm not helping you. Now, say you come in with low back pain and sciatica, what am I going to do? Well, first I'm going to do a really thorough exam, right? I'm going to put you through a range of motion. I'm going to see where you're limited, where you have pain. I'm going to look at your reflexes. I'm going to look at muscle strength. I want to see if there's irritation. I'm going to look at the skin. Are there things going on around those segments that are indicative of something going on? I mentioned edema, or sometimes you can see pitting edema. Sometimes there's hair loss along the dermatome, the sensory area of the leg where that nerve has been irritated for a long time. So there's a lot of signals. Sometimes the toenails look different. So we're going to do a good thorough exam. We're going to look at the reflexes. Is the nerve working properly? And these are kind of gross. So gross findings. So, they may not be subtle enough. Then I'm going to get my hands on you and move you around. Are those segments moving very well? I don't really rely on a ton of x-rays for this sort of thing, although I'm glad to see them if I have them, but I don't order x-rays routinely ever. I just don't. And largely, I don't feel the need for what I do to do that. So, and then what I'll do is, if there's some misalignment, something isn't working, I've got a couple tools in my toolbox. Obviously, manipulation, right? I'm going to try to do some joint manipulation, joint mobilization, see if I can get those joints to move properly, move well again. Now, if they're hypermobile, based on some findings in my exam, I don't know if I'm going to do a lot of mobility of like the cracking to get that to move, because I don't want to take a hypermobile joint and make it more hypermobile. And I think that's something really, and that does happen, and that can happen, and that can make matters worse downstream. Other things along the manipulative route I like to do flexion distraction therapy. So patients laying on their belly, their legs are strapped in, and we're stretching and opening that low back, opening the joints, opening the disc space, opening that intervertebral foramen, getting pressure off of the nerve, getting mobility in there, getting fluid to move around the joint, the synovial joint there. So I like to do that. And then I'm big on acupuncture and dry needling. I've been trained in both. I've been doing both for 25 years. I was an early adopter. I had a great trainer early on, before dry needling was ever a thing here in Colorado. One of your previous guests, Dr. Centeno, was a early adopter of that, and I learned in his practice in the late 90s about that, and then took more formal training. Nonetheless, I like to dry needle and do acupuncture and treat the lumbar segments, get into the sciatic notch space. I don't really hit the nerve, but I get in that area, and then I treat points down the leg as well. And so I get some of that started. And then, exercise, we can't neglect active care along the way. So I work with a great physical therapist. She's got her doctorate. And so we collaborate a ton. I don't really do her job, but I go down the hall and I say, let's activate the glutes. Let's activate the multifidus. Let's do some nerve glides here, things like that. And then if the patient is open to it, let's look at your diet, right? I'm very holistic perspective. Like, what are you eating? Do you have any sort of insufficiencies in B complex? Are you putting too much alcohol into your body? Let's look at and again, I would do this in collaboration with our PT. Let's look at your workspace. It looks like you and I are both at standing desks. So how much are you, getting up off your butt? Because when you sit, you compress that disc and makes it even more irritated and can aggravate sciatic pain. So those are some of the tools and techniques in the toolbox. And I have a lot of them because I don't think there is any one trick pony out there that solves this problem. You're very well aware of that, I'm sure.
We are going to take a quick break to tell you about our awesome new program called the Sciatica Protocol. If you don't have the time to see a professional, but are tired of trying to figure out this recovery on your own, then the Sciatica Protocol is for you. Harness the power of a knowledgeable physical therapist through your phone. It takes no more than 7 minutes per day, and it is designed to help you recover as quickly as possible. It is simple to start, and all you need to do is log into ifixyoursciatica.com/the-sciatica-protocol and fill out the 9-question quiz to begin. The link for the program is in today's show notes.
Yeah, there's so many tools out there, and I think one of the really exciting things that I heard, and as you're describing this, was this concept of the fact that because the sciatic nerve is it's such a long nerve, it's so long, and it doesn't even begin the moment it exits your spine. It originates over at your brain and spinal column, and so you're looking at various different areas of which this nerve or the nerve origination can get irritated, not just from a biomechanics, like what structures are there irritating, but also being able to say, okay, what are these? Well, from a joint perspective, we're looking at the hypermobile joints, the joints that actually move way too much versus the hypomobile joints, which is something that doesn't move very often. And so I think a lot of people, when they're considering seeing like various different professionals, they really don't know what to expect, because you go on the blogs and they're like, yeah, you're going to go through an evaluation. And that's the extent of what they say. They don't know what that's like. And so for you to describe what that is, I think it's really impactful and important for people, especially if they are on the fence or not really quite sure what to expect from a chiropractic visit. One of the things when you shared the vitalistic side versus the mechanistic side, it's great that you brought up the concept of like chi and energy flow. And I think one of the really interesting things, and you notice this as well, when it comes to like chi and energy flow and all those various different points, when you go into a cadaver, those chi and energy flow points are actually the very similar areas of where our peripheral nerves are. It's all the nerves that actually exit our body. And the nerves that we have, they're pretty much cords that conduct electric and chemical activity that send signals. And when you have a blockage or a dysfunction, it's going to address both up the chain and down the chain. And to be able to look at it from the energy standpoint, or I think you said the innate healing intelligence, but then also the mechanistic, like what are the actual roadblocks in the way? And I think it's important for us to be able to look at both, because the human body, we're not just like we're more complex than the typical supercomputer. I know artificial intelligence is starting to become more complicated, but ultimately it's a series of code. For us, we're biological beings. So we're having cells, various different systems that interact with each other. And because of that, it's important for us to be able to collaborate with various different professionals. I think when people look at chiropractic care, I think the most common term that they hear is a crack your back, right? And so in the physical therapy world, we call that cracking a cavitation. And so in the physical therapy world, we say that the cavitation, that crack, is not necessary. You don't need to hear or feel that in order for you to experience those true results. On your end, as a chiropractor, what are your thoughts, or what's your view on the whole cracking mechanism and how that's interacting?
That's a great question. Let's use the middle-aged, even 60-year-old woman, right, who comes to me who has joint arthritis. I might not want to, well, a couple things. So as the joint space narrows, which it's going to happen as we all age, the air change, the pressure change in there that creates that crack is not as big as when we're younger. And so you're not going to hear that crack. And that crack is not the, be all to end all. That is not our goal, to get everything to crack. Our goal is motion. If there's lack of motion, we want to increase and improve that motion. And so I tell a lot of people, they're like, oh man, I used to crack a lot when I was younger. Yeah. So that's what I explained. That joint space is narrower. The amount of volume of air in there, going back to Boyle's gas law, is smaller, the pressure's less, and so there's less ability to hear that or make that happen. That's not the be all to end all. Also, some people's joints are arthritic, and that just trying to get that to crack is creating more irritation and potentially damage to those joints. So that's not the goal either. And I think people need to take that off the table as, I got to hear myself crack, otherwise I didn't get anything. Again, the goal is mobility. Now, perfect case in point, and I had a long stretch there when I was treating like 60 plus people with sciatica or spinal stenosis. I don't crack those people. I don't even get them on their side. I do not try to manipulate them because I just already know that it's not going to be the beneficial thing. What I do that gets a lot of relief for people is acupuncture, and then the flexion distraction, opening that area up, and getting it mobile, moving that way. There's zero cracking that's happening there. And sometimes they're disappointed that that's not what I'm going to do to them. And I explain all this, and I'm like, but you're not, 30 anymore. You're not even 40 anymore. You're not even 50 anymore. This is the better thing for you at this point, right? Like, as our life progresses and as our body changes, right, we're not doing the same things we used to do to it when we were much younger. And so, sometimes that takes education and repositioning that thought process with people, because the crack is not necessary in order to get the end result, which is largely relief that we're looking for with people.
Yeah, I 100% agree with you. And I think a lot of people think, they're like, I need this crack, but like, you do a technique and they're like, I didn't feel a crack. I don't think it worked. And then we probably ask them, well, how do you feel? Like, do you feel any better? And they're like, well, my pain is gone. It's like, well, if your pain is gone, you didn't necessarily need the crack in the first place. And so it all kind of centers back on, if someone's coming in to see you for pain, like, they want to make sure that they're leaving with, hopefully, they want to leave with less pain with that. And so let's talk about some of the common trends or issues that you see with someone who's dealing with sciatica pain. So an example, I'll give an example from my end. Usually I see we'll say three major categories of people when they're coming to see me. Either they prefer grounding forward, they prefer more kind of like the flexion based, touching their toes, all that stuff. And I often associate that with more of an arthritic spine or stenosis. And then you have people who are a little bit more extension based, the people who like to do those back bends and standing up a little bit more. And that would say that's kind of, if we were to kind of categorize it from a tissue standpoint, I would categorize it under a little bit more of a disc irritation. But then we have the folks with the lateral component in regards to maybe forward bending or backward bending doesn't help, but if they lean towards or away from the side of pain, that itself actually helps me figure out, okay, well, so those are the three major categories. And then the fourth category is oftentimes that people are experiencing a lot of pain when they're doing specific activities. And that's when we're focusing specific on movement, exercise, and also just looking at the specific activity that's causing them pain. What are some of the common things that you see?
Yeah, very, very similar, right? Flexion, that's part of my exam too. So when you're doing a slump test or a seated straight leg raise, or you get them into flexion and it hurts, then I don't want to do a whole lot more in that direction. And I always ask, do you get more relief in extension or do you get more relief in flexion? And then we try to work in those directions, and giving them exercises more in those directions. similar with the lateral bending and things. And so sometimes the trigger where I need to get some imaging as well. If there's a lot of disc related pain, then, I might talk to the physician and say, here's what I'm finding. And I think, now's a good time to probably get an MRI. I'd rather use an MRI than an X-ray, because an X-ray isn't going to show us very much. It's not going to show us anything about the soft tissue or the disc. So we might as well get the right tool for the right job and treat the person. That's another important thing, is, like, we're not treating the picture. Like, we can take eight out of 10 people off the street. We'll have a positive MRI, but not have any back pain. So we got to be careful to treat the person, not the picture. That's why I'd rather start off with the exam and then make the decision about whether we need to get any sort of imaging, so we don't treat, something that's not really causing the problem. And then again, and I think this is really important too, because I have worked with some physicians who really, it's just maybe their way of doing exams where they've compartmentalized too much. Oh, if it hurts an extension, it's a facet, it's the joint. But that can be, as you know, from some of the McKenzie protocols, more disc related stuff. And so I think we got to really tease it apart and try to make a good diagnosis and put all the pieces together. There is just no one package, and everyone's a little bit different when it comes to those different kind of exam findings. And I think this is really helpful. This is where the team comes into play. Sometimes physicians and surgeons or physiatrists that I've worked with have seen different things, different presentations than I've seen, and vice versa. So that's where I really love to collaborate with them. And again, I walk down the hall to the PT, and before we share our diagnosis, we kind of share our findings, and then we talk about what we found, because I don't want to influence her. She doesn't want to influence me. And that's where we get some really good. So I'm with you on that. Those 4 different kinds of things. It matters, and you got to put it all together with the patient presentation, and if there's any imaging at that point.
100%. And I think what's you brought up this concept. It's like, okay, you're bringing up your findings, like you're getting all this information necessary to help you make a decision. And I think where a lot of people fall short is that when they're working with a specific professional, maybe they're not necessarily getting all the information. And the truth is the fact that we're not going to be able to get all the information during the first visit. But also, I think it's important when it comes to information gathering. I often tell the clients that I work with, like, no information is too minute. And so the thing is that in recovery, and this is my viewpoint, is like, in recovery, you're going to get as much out of it as much as you put in. And so if you go to a doctor, if you go to a physical therapist, chiropractor, you go to someone like me and you're like, my back hurts, and then that's all you say, and you don't tell me anything else, I'm only working based off of the fact that your back hurts. And so it is important from a clinician side to be able to ask those deeper questions, but it's also important from a patient side that whatever you're experiencing, anything that you find or think that is related to the pain that you're experiencing, you got to reveal it to the provider. Like, that's the big thing. And I think oftentimes, and I see this in we'll say the insurance physical therapy world, because oftentimes they might not necessarily have the time. They're like one of 3 patients. And the person says, well, I told them I had back pain. They give me all these different exercises. But truth be told, it's a 2-way street. Clinician needs to get asked all the questions necessary for them to make a decision. But then you also need to provide that information as well. Because if we don't, then we're really just shooting in the dark, hoping something sticks, rather than let me get a little bit more information. This information drives me to these specific decisions. Exactly.
Sometimes I feel like I'm interrogating people or like just grilling them. Does it hurt to sit? How long does it hurt or how long can you sit before it hurts? Does it hurt to walk? How far can you walk before? Does it hurt in bed? Does it hurt when you lay down? Does it hurt when you roll over? Does it hurt when you get up and out of the chair? Because there's certain conditions that, certain activities bother, and people don't really think about it because they're just, like you said, they're like, my back hurts, I got back pain. But all these little clues, and a good clinician knows what questions to really start digging down. How far down your leg does that sciatica go? Is it just in the knee, in the thigh? Does it go below the knee? Okay. Do you have pain in your butt? Do we need to look at the piriformis? There is a lot of detective work that goes on. And I even go farther than that. I ask every single patient about their sleep, because as we know, poor sleep, it increases cortisol. It just drives a million bad things biologically in our body. And I ask about mood every single time, anxiety and depression. And here's a great one. I'm treating a guy right now who's had bilateral sciatica, worse on one side than the other. They did a 2-level fusion. He had a ton of major trauma in his life in the last 6 months. And guess what? He's not getting any better. He's no better from the surgery. They're upping his drugs. He's still miserable. He's going to go on disability. And I started talking to him about some of his past trauma, suicides in his family, children, suicides, things like this. I mean, that is now playing a role in his life and in his health. And I'm just honest with him. I'm like, until you get some of this dealt with, and you need to go get this dealt with, I'm not going to be able to help you. I cannot override some of these things that are going on in your body that are coming from, really PTSD, somatic trauma, things like this. And I have pushed him into seeing a therapist, because when you bring this up, even with him, he starts crying in the room, right? So this is another pain point. It's not just sitting, standing, walking, bending, it's higher up. So I think, as a good clinician, you got to go deep and ask the hard questions. And I'll be honest with you, 20 years ago, when I started asking about depression, it was a hard question for me to ask. But now it's super easy. And a lot of people suffer from anxiety and depression that make their pain worse as well.
Yeah, especially in the world that we live in today. I mean, the mental health is starting to get even more of a spotlight, because the resources are there. And there are people that are there to help you. And often, and I'm so glad that you said, listen, like, there's only so much that I can do from a physical standpoint, but you're dealing with something internally, and I can't do much unless you address that. And the truth is that people are concerned about losing business because of that. But the truth is that we all got in the business to helping each other. And so for you listeners out there, it is important that the clinician that you're working with, just like Mark said, looks at everything. And if they can't fix you, they refer out. And that's something that I also do as well on my end. And that's a very important thing. And so we're already starting to touch base in regards to, like, who would not benefit from the chiropractic tools and modalities. So we have folks who are actually dealing with a little bit more, not a little bit, but a lot more of the psychological, emotional, that would actually benefit from seeing more of like a psychotherapist or a behavioral therapist. So there's any other criteria, things that, like you said, if I can tell within 6 visits that I can't help you. So what are some other things that that you observe that you say, okay, this would actually require the help from someone else?
Super acute herniated disc, super acute low back pain. I know even some of the physicians I work with want me to come and examine a patient, which I will do. And their back is hot and it's acute, right? They got that antalgic lean. They can't, cough, sneeze, laugh bothers them. That's not somebody I want to see right away. There's not much I can do for that person. If they can't move around, getting up and off the table very well, and they have super limited range of motion, I would rather have them get on some NSAIDs, some non-steroidals, and calm that down first. So again, I get paid the way I get paid is, I wish it wasn't fee for service for everyone. I don't get paid fee for service. My only objective is to help people get better, right? I'm not there to have you come in 60 times because I get paid more to do that. So it's easy for me to say, and you brought it up, we're all in it to help people. It's easy for me to say, I'm not ready to see this person. So super hot, acute, low back is not somebody I want to see. Somebody who has a lot of other issues going on, like they have generally overall super poor health. They're smokers, they drink, they're unhealthy in a million other ways. They're I can tell they don't exercise, they have poor diets. I mean, we can only, we're trying to turn that into improved health. And when that bucket is muddy or it's empty, there's only so much you can do with that biology. Again, I'll give that a shot, but that's where I limit things to like 6 visits. That's where I can start to tell. If you have symptoms that are unresolving after a few visits, that's something I can't help. Or you've got, weakness and numbness and tingling and serious weakness, foot drop, right, in the leg. Sometimes we see that with a really long or acute case of sciatica. That's something that needs to be addressed a little more aggressively that I'm not going to be able to help. And that's when I start making referrals. Certain red flags, and I've seen this more, and I've only seen this a few times where, doc, my pain is so bad at night, right? I remember that guy. He had cancer. And I only saw him 2 or 3 times. And I went back, that's when I was working in primary care, and I went to his primary care doc. I was like, I think we got to get some imaging on this guy. And sure enough, he had cancer. So those sorts of red flags are people that I quickly, refer or, don't move fast with. And what's interesting too is I treat a lot of multicultural people here in Denver. There's a lot. One day I treated 7 patients from 7 countries in one day. And it's interesting to see to put this work on top of people who have zero context around it or acupuncture around it. And you have to be careful how you do that and how you approach them, and sticking needles into people when it's totally foreign to them. And so I'm very conscientious about people from other cultures and what they expect with hands-on. Not everybody gets touched like you and I touch people. And so I think we have to be very aware of how we're moving into people's space like that. So those are some of the top things that come to mind.
You bring up some really interesting topics. I mean, for sure, listeners out there, when you see a clinician and they don't ask you about like going through a red flag screen, that is to me, that's a huge red flag. It's like, you got to find someone. It's like, if no one asks you about the numbness and tingling or anything else that might be related, that is something where I think it's very important. And I've talked about this in other episodes, also in the sciatica protocol that I have on the site. You go through red flag screening. If you present with any of those red flags, you should get medically evaluated first before you do anything else. And then if you're cleared of those, if you're cleared by your doctor, awesome, go ahead and do whatever you need to. But if you haven't talked to your doctor about those red flags or those things that are strange that has come on since your pain, you gotta talk to the doctors about that, because there's definitely something that could be something there. And we want to make sure that you are all protected. That's the big thing, because the tools that we implement may or may not help, but we want to make sure, may or may not help in the presence of red flags. We want to make sure that we're pretty much dotting our I's and crossing our T's. And you brought up this has inspired me for another episode further down the line, are the cultural views of pain and biomechanics and stuff. So that is something I'm putting down. And so, Mark, thank you so much. This is really, really helpful. Really good, clear information for what people can expect from chiropractic care and how the profession can actually help from a tools perspective. Now, I always like to have listeners leave with some sort of action, whether it be how to find a clinician or some things that to take care of themselves. So with your experience, like, what are the biggest action steps that people can take leaving this episode?
I think a couple things, really. Keep in mind, and you know this, Ashley, a lot of back pain goes away by itself. Imaging does not need to be the first step. You don't need an MRI or an X-ray immediately. Try some conservative things first, some heat, some ice, some rest, not lying down though, not like bed rest, none of that. That does not work. That is not recommended. We want you to remain active. The Indians used to walk in dried up riverbeds because that undulating movement of their pelvis and their back was therapeutic and healing. Old people sit in rockers because that movement of the spine is also very helpful. So we don't want you laying around. So no imaging right away. Stay active as much as possible. Talk to a family member, a friend about your symptoms, and if they have had a good chiropractor that has helped them in the past. And then I think you need to find out, were they that mechanistic chiropractor or that vitalistic chiropractor? Because to your point, the exam, the red flags, all that stuff needs to be vetted out, and make sure you're not missing something really obvious. And then, patients ask me all the time when I'm done with them, because I don't have a private practice, where can I find a good chiropractor? And the only really reliable source, there's a couple of them. The Active Release Technique website, YART, Active Release Technique, because, I've had some of that training. The people in that organization are more mechanistic based. They're physical therapists, they're chiropractors. They understand biomechanics and the anatomy and physiology really well. They generally have multiple tools in their toolbox. And some of the people that are trained by, and most of them are about the same, similar, but trained in kinesio tape or athletic taping. I'm a rock tape trained person. Again, so I like rock tape. I love their training. I've taken numerous hours of their training. And so they probably on their website also have good clinicians that are listed, again, who have multiple tools in the toolbox. No, there's more going on in the body than just misalignment, because we're all interconnected that way. We're holistic. So those are the two resources that I recommend. But, day one, you don't need to go see a surgeon. Don't do that, and same with imaging, because we'll find things on imaging that could lead to a procedure that you never needed. So start off slow, ask for referrals, go to those places, and look for resources there.
Awesome. Really good, clear action steps. I really appreciate it. Mark, there's probably some people who may have some follow-up questions. If you're up to answering them, what's the best way to get in touch if they have anything, or they probably also want to hear a little bit more about the benefits that you are providing for some of the companies you represent. So what's the best way to get in contact?
Right. Let me give you my website or my email address. You can reach me at doctesta, DOCTESTA @hotmail.com. That's probably the best place to reach me, where I can help answer any additional questions or basically, help you with good referrals.
I love it. Dr. Mark Testa, chiropractor, expert in just taking care of people. I really appreciate your time, and I know that the listeners have been as well. So thank you so much for joining us.
Thanks so much for having me, Ashley. I appreciate it.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.